Hello, my name is Carrie Ketchum, and this is my intervention study presentation on the topic of varicella, or as it's more commonly known, chickenpox. I'd first like to talk about the public health burden of chickenpox. In the United States, the public health burden has been greatly reduced since the implementation of the universal vaccination policy in 1995. Prior to that, as you can see here on the slide, an average of 4 million people got chickenpox a year, 10,500 to 13,000 were hospitalized, and 100 to 150 died each year. Now, that's been greatly reduced since the implementation of the vaccination, but in other countries where universal vaccination is not being practiced, you're still seeing those same kinds of numbers in terms of percentage of their population that are suffering from chickenpox. One thing that makes chickenpox a hard disease to provide an intervention for is the fact that it's a very long period of time when you can be contagious, up to 2 weeks, and that also starts a few days prior to the onset of the rash, so it could be when you're asymptomatic and you don't even know you are carrying the disease. So that makes it very hard to intervene. Serious complications are rare, but include the following: dehydration, pneumonia, encephalitis, bloodstream, bone, and joint infections, and disfiguring due to secondary bacterial infections of the vesicles. Also, there are some birth defects that can occur if pregnant mothers get chickenpox. Complications are most commonly seen in those who have an immunodeficiency or in older adults, or adults, I should say, of all ages. Once you're an adult, definitely the complications become a much more common occurrence. Case fatality ratios in healthy adults, for example, are 30 to 40 times higher than among the most commonly affected group, which is children aged 5 to 9. Obviously, the easiest way that you could intervene in preventing chickenpox would be through vaccination, but the World Health Organization doesn't recommend universal vaccination in developing countries for a few reasons. Number one, obviously, there's limited financial resources, and vaccination can be very expensive, and they believe that that money could be better spent on other vaccines or interventions that have a greater potential for affecting public health. Also, this vaccine, like many others, is difficult to store. It requires a certain temperature, and it has a relatively short shelf life, which means like once it's opened, it has to be used relatively quickly. Risk factors and prevalence of these risk factors for chickenpox are as follows. Close contact with an infected person. Obviously, it's a very contagious disease, so being around someone who has it is a great way to catch it. It can be transmitted via droplets, so through like a liquid medium, the air, or direct contact. So again, very contagious. And this is the area I'm going to focus on in my intervention. Being an age less than 3 years old, peak incidence between 5 to 9. I have some data here in a table that illustrates this point. Note that this data is from Taiwan, and it's dated for 2000. Taiwan now also is a universal vaccination country, and so their numbers have dropped dramatically. But at that time, these were their incidence cases for 2000. You can see here that children ages 0 to 9 make up 85% of the cases in this data set. Having an immune deficient state, again, as I said earlier, just having any kind of immunodeficiency makes you more likely to be attacked by any kind of viral infection, including chickenpox. And also the time of year. There's a higher incidence in late winter and early spring, and obviously that's thought to be due to people being kind of cooped up inside, and you're more likely to be in contact with others, and therefore with others who are contagious. We have some data here again from the Taiwan data set. The next page is going to show a data table that illustrates kind of how some models that were formed to show how season is related to how likely you are to get chickenpox. And so they compared summer as their baseline model, and they compared winter, spring, and fall to summer. So over here in the model 4 column, they have the model for each season versus summer, which is over here in the left-hand column of the variables. And then it also includes temperature, clinics density, meaning how many health clinics they had based on the population size, and also population density, so how dense or sparse a population was in a particular area. So model 4 is the full model. It's taking into account all of those variables, and then as each model moves to the left for model 3, you can see that the population density was removed. And then for model 2, they removed the variable clinic density. And then over here in model 1, we have just the seasons versus summer. Using the full model, so like trying to account for all of those variables that might be confounders along with just season, we still have a relative risk or an incidence ratio for winter versus summer of 1.31 and for spring of 1.35. Okay, so even with all of those other confounders included that they thought might also be related to that incidence ratio, those are both still coming out as significant. And in fact, autumn does as well. Oh, no, wait, autumn doesn't. I thought autumn did as well. But you can see that spring versus summer and winter versus summer are significant. These little asterisks are indicating that the p-value for these tests was less than 0.001. And that's in all of the models. So no matter what variables they included, those still came out as significant. My target for intervention, as I said, was going to be having close contact with an infected person, and that's because that's really the only risk factor I can hope to impact. I can't control age or someone's immune system status or what season it is. So I'm going to try to attempt to intervene in this having contact with an infected person. Studies have already been done to attempt documenting the effectiveness of various methods for reducing the spread of a respiratory virus, which varicella is. The varicella zoster virus is just one of many respiratory viruses, and these studies showed that there's many different things you can do to try to intervene. So I found a systematic review that looked at a number of studies, including randomized trials, cohort, case control, crossover designs, and time series studies. The results of the study showed that the following physical measures were very effective in preventing the spread of a respiratory virus. So we have hand washing more than 10 times a day, wearing masks, gloves, and gowns. Now the strength of these studies is that there were many studies included, 58. Actually there were 59 studies, but only 58 of them had what they considered viable data to study in their systematic review. So they had a lot of studies conducted, which included many different testing designs. However, a limitation was, right at the beginning of the systematic review, it said the quality of the studies analyzed was listed as poor or mixed quality in many cases. So my objective is to see if the interventions of hand washing, mask wearing, and this is by the infected individual, and vitamin supplementation can significantly reduce the incidence of chickenpox during the months of spring, March through May, in previously uninfected 5 to 9-year-olds in London, England. The reason I'm using these different interventions is hand washing is something that's very easy to do and something that's been shown to be very effective in virus control. Mask wearing, if it's just by the infected individual, would also be a fairly easy intervention to apply, and a vitamin supplementation also, just something that the kids could take once a day. I'm choosing spring because that's when the highest incidence has been shown to occur, 5 to 9-year-olds because they are most commonly infected, and London because if I did the study in London, England, there wouldn't be a language barrier, and also that is a industrial country that is known not to use universal vaccination. So my study will be community-based. I'm going to choose a randomly selected elementary school in London. About average size, that's about average size for London, is about 250 students. And I'm going to try to make sure that it's as close to that 5 to 9-year-old range of students as I can. For comparison purposes, I will also choose an elementary school as similar as possible to that school in the area, and make sure that they will not be using any of the interventions that I am proposing. Students who agree to participate would need to follow the following interventions: wash their hands thoroughly for 20 seconds or longer with soap and water at the following times of day. So I have a number of times a day they would need to wash their hands. If they do contract chickenpox, they will agree to wear a mask during school hours for all the time that they are considered to be contagious. And as a precautionary measure, we would also make sure that students who have a household member with chickenpox would wear a mask until it's shown whether or not they are contagious. And then I will also have the students take a daily multivitamin supplement that includes zinc, echinacea, and elderberry, which are compounds that are suspected to have antiviral qualities. I'm going to use a relative risk ratio to determine whether or not my intervention was successful. I think that with about 250 students in the group, the sample size should be sufficiently large to give me a good power value. And I also think that this is probably about the biggest size I could carry out the study within and still have it remain manageable, meaning I could make sure that the interventions were being followed and track all of that data. I'll then summarize the data in a table below, such as this, so whether or not they were in the study group or they were in the control group, whether or not they developed chickenpox or did not, and then I can calculate their risk over here, giving me a relative risk ratio as shown on the bottom of the screen. My anticipated outcomes are at the conclusions of the study. I hope I will see a relative risk ratio that's less than 1. That would indicate that the intervention was successful because you have a reduced risk of developing chickenpox. If I do get a relative risk ratio of less than 1, then further studies might be warranted. Those studies could include testing of each of the intervention strategies separately, or testing a different combination of a vitamin supplement, maybe try some different antivirals or less antivirals, or testing the intervention in a different season of the year. Since my study is only being conducted during one season, I feel that completion could occur in a relatively timely fashion, less than a year from start to finish. Strengths of my design, it uses interventions that are already suspected to be successful, but can't be justified due to lack of quality data, so maybe I could help add some quality data and some stronger support for those interventions. The cost would be low relatively speaking, assuming that they already have adequate hand washing facilities, which hopefully they do. Also, a vitamin supplement shouldn't be too costly. Introducing a new intervention in a moderately sized setting and in a controlled fashion. So the vitamin supplement is something that I hadn't found tested, and this would be a good way to introduce it. Includes a control group for comparison, so that's always good. Uses a group with a known high risk for contracting the disease that's still capable of complying with the intervention strategy. So I wanted to pick a group where I knew that chickenpox was going to be likely to occur, and I also wanted them to be able to follow my instructions. And so I didn't want to pick kids who were too young, and I feel like that 5 to 9-year-old group could definitely follow these interventions. As with all studies, mine has some weaknesses, of course. I might not be able to find a school that wants to participate. The children could and probably would be exposed to chickenpox outside of their school day. Infected children might refuse to wear a mask. Kids might not take the vitamin. There's a lot of inconsistencies that could occur with applying the intervention, but that could obviously happen in any setting. With 3 interventions being applied, we wouldn't know the contribution of any particular one. And the study only occurs during the spring, which of course would limit my generalization to other times of the year, as well as a child's exposure status at the beginning of the study might not be fully known or understood. Despite these weaknesses, I feel like this would be a very good intervention study to propose. Like I said, I especially like the idea of including the vitamin supplement, which is something that is kind of controversial, that holistic approach. But it would be nice to see if that, in fact, those antiviral qualities can help reduce the spread of maybe not just chickenpox, but other viral illnesses. I've included my bibliography. These are different sites that I used to gather information for each of those respective slides, and my works cited. I look forward to reviewing other people's projects and answering questions about mine.